thank you so much. I want to thank all of you for tolerating this presentation at a distance. It's made it a little bit easier for me to teach the 65 undergraduates that were so happy to see me this morning at 8:50. I also am sorry to miss my friends out there, Ted and Shalraj, and yeah, but most importantly my friend Judy Murphy. We look alike, and she is actually older than I am.
17 days.
So I'm going to talk with you for a short while about patient self-monitoring and a concept that's earned our work here called observations of daily living. Next slide, please. On the slide in front of you, you should be seeing a timeline. Picture a year in the life of a person who's had an MI. So in January, the person ends up in the ICU, and then after a few days is discharged, goes home, takes medication. We hope goes to cardiac rehab, regains his or her life. He takes medications that are tracked on an RFID tag, continues to see the clinicians throughout the year, has an imaging study at the end of the year, and then by the end of the year is actually better, maybe just has a small scar left. Most of our clinical information systems that have been developed, indeed most of the things you've been talking about today, run along the vertical lines of this image. That is, our information systems are institution anchors. But what the patient experiences is on the next slide, please. And here you see what we call the care between the care. What happens in this interval between the time that we see the patient and how do we build information technologies to capture this information, and importantly, what is the nature of the experience of care between the care? Next slide, please. During Project Health Design, we learned and recognized that professionals are experts in clinical care, but people are experts in everyday living. And if we want to engage people in the care between the care, and we want to use information technologies to do this, then we need to be sure that we can listen to them in everyday living and understand what their experience of health is. Next slide, please. During the Project Health Design experience, which has been about 8 years now, involving 14 teams around the country, what emerged was that people don't talk in clinical jargon to each other. They make observations of everyday living. And these are pretty persistent, somewhat idiosyncratic sensations that individuals use. They're the thoughts, feelings, behaviors, and actions, and even exposures that give an individual cues of when to take healthy action. Susanna Fox uses as her ODL her skinny jeans. If she can fit in them, her diet's going fine. If she can't, she has to rethink what she's eating. Another person uses as her ODL her ability to sing through an entire hymn in the church on Sunday. If she can do that, she has enough breath. Her asthma control medications are working fine. If she can't, she knows that there's a problem emerging. ODLs are cues towards action rather than indicators of pathology. On this page, you see a baby crying, someone bending over with a large pitchfork, or kids being able to dance. These indicators that my body is working as it should, that I am able to do what I need to do, or something is wrong, is what a patient first attends to. They don't attend to blood pressure, glucose level, or even pain on a scale of 0 to 10. They pay attention to their bodies. I'd like to take a few minutes with you to tell you how we learned about the ODL through Project Health Design. Next slide, please. Project Health Design was a series of projects designed to bring an individual's experience of everyday living together with the health concerns raised by them and their clinicians and innovative technologies to try to see how we could better use technology, not to record the points of care, but to support the care between the care, to assist people in making choices in everyday living. Now, I can speak of this at length, but our participants do a much better job. So on the next slide, I'm going to have you watch a short video I'll watch it out here in Wisconsin, so we'll pretend it's network TV. But I'd like to have the video begun out there, and then I'll be back to talk to you.
Project Health Design is a bold new program to create the next generation of personal health record systems. A national program of the Robert Wood Johnson Foundation's Pioneer Portfolio, Project Health Design receives additional support from the California Healthcare Foundation. Drawing on the ingenuity of 9 interdisciplinary teams of grantees, the program is designing and testing personal health applications that help individuals and families better manage their health and health care. The grantees have pushed the potential of personal health records through designing PHR applications that put users' needs front and center. They go beyond access through personal computers by using increasingly powerful mobile devices. The following is a glimpse into one grantee's innovative project.
My name's Jim, and I just turned 36. Tina and I got married a couple of years after we graduated from high school. I found out I had diabetes the same week we learned Tina was pregnant. I felt like my life had been turned upside down. Managing my diabetes takes a lot of time and effort, but I try not to let it control my life. I still play basketball with my buddies from high school, and I've taken up running. Plus, I do woodworking for a living, and that's pretty physical too. Well, even though it's been 13 years since Kayla was born, and I found out about my diabetes, things haven't gotten less crazy. We just bought a house, Tina's got a new job, and I finally decided to take the plunge and open my own cabinetry shop. With so much excitement around here, it's been harder than ever to stay on top of my diabetes. There are so many things to do, like paying attention to my blood sugars, figuring out what to eat, how much to exercise, and how much insulin I need. Understanding how all these things fit together is really tough. So I was pretty fired up when I read about a new service that coordinates all that stuff for you, right from your phone or computer. Now, I didn't know exactly what to expect, but Kayla helped me set everything up, and when I saw it was based on Google, it seemed simple enough. And I always have my cell phone, so it's easy to be able to see how I'm doing, anytime I want. A couple of weeks after starting the service, I have an afternoon meeting with the bank. I need a loan to open the shop, and it feels like my whole future is riding on it. I'm a nervous wreck the entire morning before the meeting, so Tina tells me to stop worrying and go for a run. 3 miles in, I hear a beep. It's a text message letting me know my blood sugar level is getting low. I stop, take a couple of glucose tablets, and rest before I head home. Now, hypoglycemia is the last thing I want the day of an important meeting, so I'm glad I have this safety net. A month later, I've nailed the loan, and 2 months after that, I'm ready to open shop. We have a little celebration, complete with Tina's homemade cooking. The system helps me plan ahead so my blood sugar stays on track. Before bed, I always check out my iGoogle page. These days, I'm happy to see my blood sugar levels are usually fine when I check. If I need it, the system gives me advice on different things I can do for myself, and I can decide what's best in these special situations. The system really helps me keep my diabetes on track. I can see how what I do affects my blood sugar in different ways, like how I eat, my exercise, my medicines, and my stress. Now I get how all that stuff fits together, just like fine woodworking. Each morning, I wake up feeling great. I'm not worrying as much about my diabetes anymore because the service gives me tools I can use, when I need them, to take charge. So, now I've got enough energy for my family and to run my own shop.
2 professional teams helped grantees address concerns and take advantage of opportunities identified during project development. Experts from Sujansky & Associates worked with all 9 grantee teams to identify technical requirements common to all projects and implement them in a web environment, demonstrating that a common platform can support multiple personal health application tools and that the technology for using personal health records should be separated from the record itself. As well, a team from the University of Miami Bioethics program helped grantees identify the most pressing ethical, legal, and social issues associated with their projects, how individuals control access to their health information, how to manage privacy, and the implications of shifting personal health decisions previously shared with health professionals to consumers alone. Project Health Design is demonstrating a powerful vision of how personal health records and new technologies can empower people to better manage their health and healthcare. To learn more about Project Health Design, visit our website at projecthealthdesign.org or contact the Project Health Design National Program Office, which is based at the University of Wisconsin-Madison School of Nursing.
This and 9 other videos like it are available on our website, and they're licensed under Creative Commons, so you're free to use them if they would help in illustrating these ideas to other people. Can we go to the next slide, please? What I want you to think about for a few minutes is what's important to Jim. Well, what he learned from the video is that he's negotiating a loan, he's opening a shop, he has stress, is doing exercise, taking medications, and is worried about experiencing hypoglycemia. Which of these doesn't have his no-med code? Most of them, actually. So what's important to Jim are these experiences in his life and how learning ways to manage them. Let's look at the next slide and see more in depth about the language. The language of health and everyday living spans a wide range of terms: playing basketball, staying on top, medication, exercise. These terms take on meaning to Jim that might be different from his clinician. Next slide, please. What we have here is language that is always patient-focused and sometimes patient-defined. What we're used to working with as health professionals and informatics professionals is on the left side, not on the right side of this line. So let's take a look at what happens to language. Go to the next slide, please. And you'll see that the clinical terms fulfill an explanation that might be patient-focused, but not necessarily meaningful to the individual. Observations of daily living do seem to fulfill that need. Next slide, please. So if we scatter the terms, we can see them beginning to cluster, things that are more relevant, more familiar to clinicians, and things that are more familiar to patients. As we continue to understand how to support health in everyday living, we need to remember that both sets of terms are necessary for us to understand patients, and both require informatics support. Sometimes they're going to be messy. The term stress might have a clinical meaning and a personal meaning to the patient, and we need to recognize that sometimes even the same word brings about different meanings. Next slide, please. Health information technologies have the potential to bring the language of everyday health into clinical care. So the professional terms of blood glucose, activity tolerance get complemented and enriched by the personal terms of open my own shop, go for a run. These are things that help the patient know they're doing well and also give us cues to know what they pay attention to. Next slide, please. So in our Project Health Design studies, we found the observations of daily living as displayed on this wordle. Some of them look pretty familiar to what clinicians are familiar with, like stress or depression. Some of them become personal to the individual, like socializing or triggers or activities and changes, bonding. These terms are terms that give us a cue what to explore more with our patients, not necessarily what's wrong with our patients. Next slide, please. Patients like following or monitoring their observations of daily living because they found that they were able to share their experience better. You see, sometimes there's just a feeling of not being so alone, that someone knows what's going on with them, or that by monitoring them, they've actually seen improvement in their health. Some patients told us that it's easier to summarize the between-visit events to their clinician so they know what to focus on. But others told us that it's sometimes hard at the end of the day to focus on keeping track of this. So we have to remember that having patients track their health information actually puts a burden on them. We might need to help them learn how to adjust to or manage with. Some patients told us that they got so intense in watching their own experience by watching a patient's pattern of taking rescue medication, taking controller medication, and monitoring peak flows with anxiety levels, they could make a between-visit change in medication so that they can target the medication, the controller medication, better for asthma. Others found they could validate that a diagnosis was in fact correct, or maybe notice that the diagnosis was different than what was originally anticipated. This is a case of a patient who was thought to have asthma but appeared to have COPD. They found that they were able to understand, clinicians could understand the impact of sleep or exercise on pain, or understand and be able to make better informed referrals based on the patient's knowledge of their symptoms. In general, we find that while observations of daily living aren't by themselves the magic bullet, they are a key step in engaging patients in their own lives and helping clinicians to be there in their lives with them. Last slide, please. I encourage you to meet my team because the work that we did here has a lot of people involved with it, and our websites are listed there so you can learn more about our activities. Thanks very much for your time.
Thank you, Patty. Okay, next I'm going to introduce Diane Humbrack. Sorry.
No, that's fine.
Diane is actually our region, this area, Region 3 Director of the American Nursing Informatics Association. So I wanted to make sure that I introduced Diane, and they're also endorsing, as AMIA is, our conference today. And Diane will introduce our next speaker.
So it's my pleasure to introduce Judy Murphy, and I'll do a condensed version here since you were introduced before.
They just heard this.
Yeah, the Deputy National Coordinator for Programs and Policies at the Office of the National Coordinator for Health IT. So she's been with Aurora for 25 years and most currently is at the ONC since I think 2011. So our pleasure. Welcome.
And you may think you're doing a double take, like, is this the same person we just saw? Why, yes, it is. Was everybody next door? Okay, you're not going to admit it if you weren't. Anyway, what I did was created a full slide deck on patient engagement because I thought it would be helpful for you to have that in case you just wanted to shamelessly steal it and absolutely positively use it. But you're going to see some of the same slides that you saw next door in my slide deck because I wanted this to be complete. So what I'm going to do is just highlight the differences, if you will, or the new ones. Again, a bit about the why, and that's pretty duplicative in the 3A's approach, but I've got some unique stuff specifically related to nurses. So these are the replays. This is a new slide, and just to draw your attention to the fact that there's a whole tab, if you will, on healthit.gov related to patients and families. And that, again, I can't emphasize how important it is to start thinking about this space and start realizing that Health IT can be the hook to get people engaged in their own care. Similarly to what we talked about earlier, this isn't about, like I was talking about the patient-centered care and interoperability, right? We don't practice in a patient-centered way, and that's why it's not just about the IT. It is about how we practice. The same thing when we think about the care, integrating patients and families into their own care. It's about the way we practice. And oh, by the way, yeah, we can use our tools to be able to do that. So there's lots of suggestions on here. In fact, this tab is really focused on giving providers ideas about how they can engage patients and families in their care. It is not focused directly for patients, okay? So again, tools and things that you can utilize that I think you'll find real helpful. There were some questions in terms of privacy and security, and there's some good chunks of information here about that as well. We talked about the 3A's and about the pledge campaign, but there were two really important organizations, if you will, that stepped up in the nursing space to do some very particular things during the pledge campaign, and actually they're still going on. So the first one is the Alliance for Nursing Informatics. This is, how many people are familiar with ANI? A few. Many, okay. The Alliance for Nursing Informatics harmonizes all the nursing informatics organizations from around the country. So the idea here is that there's certain certain areas where it's going to make sense for us to speak with a single voice. So for example, if the government was putting out a request for information, or if the ONC was asking for comments on proposed stage 3 criteria, it may make sense to pull all of our activities together and to speak with one voice, okay? And so the Alliance for Nursing Informatics, that's a good example of what they do. We don't try to redo things that the individual organizations are actually doing. So the American Medical Informatics Association has a nursing informatics working group as one example. They're a member of the Alliance. The American Nursing Informatics Association that Diane was representing, they're a member of the Alliance. There's a Nursing Informatics Committee under HIMSS, or at HIMSS. Right. They're a member of the Alliance. So again, I think it's 28 organizations now. So what ANI decided to do was to become a pledgee, and as a pledgee to launch a campaign, which was launched in January or February of last year, to specifically be looking at how nurses can get involved in using a personal health record or a portal themselves, and then turn around and use that experience to share with their patients. So the interesting thing is, I remember when this got started, I was not on the working group that was actually working on this. I was peripheral, and I was hearing a report at one point about what they were doing. And they said, well, we're creating a button that's going to say, I'm using a personal health record, or you. And where did my mind go? To a physical button. And they were talking a button on Facebook. Which goes to show you we all fall back on our own personal reality and our personal experiences. So here is an example of the advertisement that they've got on their website about the information that they've got on Facebook. And then, of course, you can click right over to Facebook. But there were some ideas here. I'm an RN and use a personal health record, or do you? I'm an RN and use the patient portal, do you? So again, the concept was to do it yourself so that you could talk to other folks about it. Now, part of the campaign was reaching out to nurses in government and nurses in leadership roles to get them to commit. And there were some blogs and some interesting advertisements that took place during that time. Now, as a companion to that, the American Nurses Association also had information posted on their website, and theirs was really aimed at educating folks about the tools that they could be using with their patients. And so just like this headline in their website reads, ANA encourages RNs to use their personal health information as a step toward empowering consumers to manage health. And they actually had a pledgee component here. You'll see ANA press release and pledge, and then you could pledge to agree to the ANA pledge. And what was neat about it, again, was just getting a lot of people talking and thinking about this space. One of the things that I've been saying quite a lot, actually, the last year is I love talking to my friends. I mean, I really do. I like you all, you work in IT. When I use the word HIPAA, you know what I'm talking about. When I use the word IT, I don't have to describe it, right? So I like talking to my friends. But part of the problem is that we have to stop talking to each other and start talking to the nurses that don't know what IT stands for. And there's a lot of them out there, right? There's a lot of them that go to work every day and they don't think about the tools that they're using and how they should be maximally utilizing them. So when I think about my personal outreach, although I again love coming to an IT conference like this, the real outreach is toward the organizations that are specialties in nursing, or the organizations that are nursing organizations like ANA. So reaching out to the Critical Care Nurses Association, the Oncology Nursing Society, the American Nurses Association, with the knowledge that many of us have in this room, those are the people we have to help understand. Because in nursing in particular, I think, what happens? Well, we have this like love-hate relationship with IT, right? In fact, yesterday I was talking to somebody and I was talking about the love-hate relationship we have with carts. We know we have to use them. We kind of like them because they're our little island and we can put stuff on them and drag them with us, and maybe even we label them for the day with our name. But we absolutely hate them because we have to drag them everywhere we go. And we have to pull them down hallways that are carpeted. And we have to pull them across thresholds that are fat and heavy and bump across. They don't always work. They're not always recharged. We have to remember to recharge it, on and on and on and on. And so when I think about some of the newer things that we're going to try to integrate into our practice, it is going to be outreach. And so things like this A&E campaign to me are extremely important. And I would encourage you all to think about talking and spending time with the practicing nurses, and maybe you all do a lot already, to try to understand how we can get at this sort of love-hate relationship and turn it into a total love fest. And we know the tools that we're working with are not always perfect, right? And that's part of why this is so important too, whether it's the personal health record or the application that they're using to document patient teaching. It would be extremely important that it's as usable and as practical as possible. So I talked a little bit about this already in the previous talk. We got the stage 1, stage 2, stage 3 meaningful use criteria. We're moving along a continuum. This is a maturation of criteria. So as we focus and start to signal what's going to be in stage 3, I don't know for sure these are what's going to happen because, of course, this has a normal process that it goes through. But some of the things that are being talked about for stage 3 are things like patient-generated health information. Where should that fit? What should the standards be? How should we be thinking about this information? Error correction. Once we open up the medical record through any process that we're using, whether it's patient-generated information being amalgamated with provider-generated information, or whether it's strictly provider information, how would we go about doing error correction if something is found to be incorrect? In the previous session, I talked about these mashup things. What if we're taking information from organization A and organization B and mashing it up into our personal health record? Well, now we have a good, accurate med list. How can we take that med list and iterate it back into those two organizations so that the next time we go in, the information is in fact correct? So there's some interesting things to start thinking about, but these are really the areas that are being signaled that we're probably going to be looking at for stage 3. So when I was at HIMSS, Charles Boise, anybody know Charles? So he had a dream, and I kind of went, whoa, this is really a cool dream. And if you have access to the slides from HIMSS, he was in the Nursing Informatics pre-conference. But he had a diagram, and I should just steal it from him and use it because I'm sure he'd be fine with that rather than me trying to describe it here, which of course helps Patty because she can't see my slides anyway. This idea that the patient really is in the center. And this personal health record idea is maybe that is the center of the universe with the patient. And maybe when we go out to the silos, we're somewhat responsible for making sure that the silos are reconciled with the center of the universe. And that was kind of his idea, is that we'd pull information in and we'd reconcile it, and then we'd have good information again. And then we'd have another encounter and we'd pull the next thing in and we'd clean that up too. And that the source of truth becomes what we have as the patient, not what the providers each individually own. It's kind of interesting. So if you sort of picture the diagram, patient at the center is kind of a wheel and spoke kind of idea, as compared to trying to do the spaghetti of connecting all the different organizations. And especially when we think about data beyond our current reality. So if we start to think about data that is not just from provider organizations, but providers from devices that we use for our health and disease management. So things like our Fitbits, should that not be in our patient-controlled personal health record, right? Maybe if you're actually looking at it yourself, and maybe your daily weights, if you do that, or weekly weights, or whatever it is, your eating habits. Those are the kinds of things that you could start thinking about, really creating this sort of patient-centric thing. So I kind of throw that out there for contemplation. I do not take credit for that one. It was Charles Boise, but I thought it was a really interesting idea, and whether we'll ever get there remains to be seen. The Surgeon General has really been big, Regina Benjamin, on this idea of healthy apps. And so if you haven't looked at some of these things that I addressed earlier at challenge.gov, you may want to look at some of her things. Similar to Michelle Obama, she's been really all about getting people moving and thinking about our everyday habits and integrating, and this ties in so directly with what Patty was talking about when we think about those ODLs. And We talked about the Leon Rodriguez letter so that you can make sure that everybody understands you actually do have a right to this information. There's also for smaller organizations that don't have lawyers that can figure out this privacy and security stuff, there's also a model privacy notice that can be downloaded and pretty much just used as is. It's been vetted for common use. So it's a helpful piece if you're at an organization or work with an organization that's smaller and doesn't have a lot of their own resources to develop privacy notices of their own. Here's a good example of one that you could use. We talked about that already. We talked about that already, and that, and that. So I'm going to close so we can get to the meaty part of the discussion and some Q&A here with reminding you all that change starts, one by one, and that we have to think about how we are going to change ourselves, and we need to think about how we're going to change our practice to this new reality of where we know we need to go. And with that, I'll close, and we'll open up for discussion, I think, right? Thanks.
Thank you, Judy, again. Okay, and at this point, we actually want to just turn it over for some questions and answers from the group. So if anyone has any questions, we still have Patty on the phone. Patty, you there?
Yes, I'm here.
Okay, Patty's on the phone, Judy's at the table, and we have Diane also as another representative. Does anyone in the group want to start off with some questions about patient engagement, nursing informatics? Go for it.
Or comment, personal experience.
Comment, yeah, personal experience comment. We do need to use a microphone so that Patty can hear. So there's a microphone in the back. And if anyone could just raise your hand, we'll get the microphone to you. Questions? Yes, up here.
Thank you. So I find it very interesting that we're using the language of the patient, and I believe that by doing that, we're incorporating the culture of the patients. So that's just an observation.
It's kind of funny. I'm going to comment on that just because I've personally thought about it a lot. Patient versus consumer versus client versus whatever else. And it's sort of funny because, some people are extremely passionate about this. They think it should be one or the other. Me, I've never been passionate about this particular thing. I've used them almost interchangeably. I personally think what sticks is patient. And I know that we have a connotation as providers about that. It almost infers that it's an encounter with a healthcare organization and a dependency as compared to what we're trying to foster, which is a much more, broader kind of collaborative health being incorporated and not just, disease management or health encounter management. But I think it's the ones the patients identify with. I think that's exactly what they think they are when they're in a healthcare organization. So, I tend to use the patient one, even though I do mean the more inclusive, broader definition. Meaning that a patient could actually have a Fitbit on and be walking and counting their steps. And it had nothing to do with the healthcare encounter.
So I want to take that from a slightly different perspective. Like Judy, I agree with this, that the term is not as important as the person that we're paying attention to. And while the term may imply some kinds of interpersonal rules, we may have to throw all those rules out because healthcare is really different now. But I appreciated your comment about the patient's words, because this really calls attention to why we want to listen to the person. We need to understand not only what words they use, but how they apply meaning to them. And whether it's the cultural connotation of those words, or the patterns that they're used to seeing, and what in that person's mind designates that change has happened. These are important things that we're used to looking at. But we need to now remember that we have to hear them from a different vantage point, what they mean to the person.
Thank you, Pat. Another question?
So, question to Judy. And first of all, I wanted to thank you for all the advocacy for nursing that you're doing at the Office of National Coordinator. And that's really amazing to see some of the things that are happening now with the kind of inclusion of nurses as real partners in this entire health IT thing. So the question is whether you see beyond the meaningful use. So meaningful use is not really focusing, it is focusing on some part of nursing, but it's not all about nursing. Do you see nurses included more in the more advanced stages of your planning, of legislative planning in these discussions about health IT? Thanks.
Yeah, that's a really good question. So first of all, by the way, I can't take all the credit for the nursing thing. I'll take about 95% of it. No, I'm just teasing. My boss, Dr. Farzad Mostashari, actually is a wonderful partner. And you may have noticed, and it's not just been since I've been there, but the word physician never gets used unless it's physicians and nurses. And he is extremely consistent with that. And I think not only him as a person, but us as an organization at ONC, which gets more to your question, is this idea that interdisciplinary care, whether you're using that term patient-centered medical home, which is team-based care, where everybody is really functioning at not only the top of their license, but they're being used in the way that's most appropriate to meet those patients' needs. Who better to do diabetic education, and those kinds of things. And I don't mean to pick on something that we've always agreed could be a nursing thing. There's a lot of things, and I use my personal examples with my mother again, pain management. I have to tell you, I had to talk long and hard to get her to see a nurse practitioner for her arthritis pain management, because there was her belief that only doctors. And the fact that nurses could even prescribe was new news to her, kind of like the diabetes feet thing. And it's curious because, again, people have sort of grown up that way. So there are some barriers and some culture things that we really do have to break down. So specifically getting to your question about what's next, you might have heard ONC and myself talking about this meaningful use of meaningful use. And what I mean when I say that, and I think anybody from ONC means close to the same thing, is that meaningful use is the floor. So if you took and looked at the meaningful use criteria and thought that if you made a check mark next to every one of the criteria, met all the criteria, that you would be doing healthcare transformation, you would be wrong. The idea with meaningful use is that it's getting people headed in the right direction. It's setting some minimum thresholds about what you might want to think about or what you might consider. It was always meant to only be a stepping stone. So in an organization, if you're using it in that way and using it to think about, whoa, there's money for this, so now that we're doing this, let's do all those other things we wanted to do too. And you build it into your strategic plan. And your strategic plan doesn't say, become a meaningful use stage 2 user. Your strategic plan talks how you want to change about the way you're providing care, and a sub-point of that is achieve meaningful use so you can get the money so you can have some money to do what you want to do. So within that frame, where I personally think we're going, and you hear people talk about stage 5 and stage 7, I don't know if we're going to keep that staging word going, but what we are, I think, going to keep going is the dialogue that we've started as a nation about what works and what doesn't work. Whether it's a beacon community or whether it's a person attesting to meaningful use, we've been talking about what works and what makes a difference to outcomes. And we're getting to really making that connection. Now, do we have it all hardwired? Goodness no. Do we know what all the right answers are? We don't even know how to measure quality the best way in an EHR. We're just evolving that. But I think that's where we're going. And coupling that ability to measure with this better concept of using team-based care appropriately, I think it's just going to be a really powerful future for us. And like I've always said, well, at least I've been saying it for a long time, maybe not always, there's certain spaces that nursing just absolutely owns. And when I think about the patient advocacy role, the patient engagement role, we own this space. And what I mean by that, no one knows more about it than us. No one is trusted more than us to try to change this culture. That's why I get so obsessed about the fact that nurses should be doing some of this stuff themselves so they get some experience so they can talk to their patients. Because when we have that dialogue with our patients, they will believe us and they will understand what we're talking about because they already trust us. And no other profession in healthcare really has that relationship, that 24/7 foot soldier kind of base, if you will. So anyway, I've been talking too long. Patty might want to comment on that too.
Yeah, can I add to that?
Sure.
So I really think that meaningful use has opened up so many doors for our profession, for informaticists. On the outpatient side, you see some informaticists on the inpatient side, but on the outpatient side, there's a whole other world out there. Who's going to be helping these patients get into their portals? You know, it's going to be nurses, and maybe it won't be an informaticist, but an informaticist can probably go touch that home care nurse. And we actually have the opportunity right now to really change our profession as an informaticist, which I think is really exciting, and it's all based off of some of the foundation that's been laid.
Patty, with all of your vast years of experience, could you comment?
Even though you're younger than me.
Even though you're younger than Judy.
You know, I think that we have opportunities for engaging a lot of different people in the health IT activation strategy. But I don't think we can overlook the K-12 environment. There's an opportunity to use what's already happening in K-12 that socializes kids for discovery, that with a little bit of support from school nurses or from nurses who work with the schools, we can actually begin to get kids to realize this is not just a pathway to knowledge, but a pathway to health.
That's a great comment. And we actually heard in an earlier presentation, someone was talking about their 5-year-old and how they came to the doctor's office and they picked up, you know, an iPad, or they started inputting things, and then the next time they went to another pediatrician's office, they said, when am I going to get to type? Because the physician was typing into the electronic record and the patient, the 5-year-old, never had the opportunity. So what a very wonderful question or comment. Poppy, you're next.
Yeah, I just wanted to talk a little bit more about what Doreen mentioned about the patient's word. And I know that a lot of times clinicians, we set expectations for the patients. But when I hear that the patient says, well, I feel okay when I'm able to do X, you know, then I know that, you know, my knee is okay when I'm able to go get in the boat and row, instead of saying, you know, your expectation is to you know, walk X amount of feet. Mm-hmm. So I just wanted to make that comment because it really resonated with me about that.
Thank you. Question down there.
You were talking about a team approach to things, and I work with a PACE program. Are you familiar with those?
Yes.
In Pennsylvania, people think of PACE as a drug program for seniors, but it's what it is actually is an integrated team approach to care for people who are certified to need nursing home care but want to stay home. And actually, there are more in Pennsylvania than there are in any other state. But a problem that we keep coming up against is when CMS comes out with new regulations, or with we're dealing right now with the encounter report, data reporting thing. Because we're a team and because of the way that we work, we can't fit into anything, and they just don't understand how it works or how to deal with it. And that's been a problem over and over again with our team approach to care. And it really is a beautiful model that works really well.
Patty, do you want to comment?
I just think you make a great illustration that the IT cannot drive practice. It has to be the other way around.
Thank you. Anyone else? Judy? Anybody else? Question?
I think that example repeats itself over and over. I mean, a lot of people that I talk to, nurse practitioners who can't figure out, how to get the incentive payments, or because CMS has been, nitty-gritty specific about certain things. And all I can encourage you to do is to continue to work with, in many cases, it's actually your Medicaid folks locally at your state, because those people can feed back, it's the same agency. So they can feed back to CMS and often will help you do those things, even though they're the local folks.
Question.
So you talk about patient language, right? So we just get done hearing standards and interoperability and data sharing and discrete data. When you start bringing patient language in context, how do you map, benchmark, make those algorithms, do the nomenclature mapping so it can be something that can be tracked, trend, and used to increase patient care? Because you've now gone just the total other side of standards for interoperability to full text and full context in the patient's language that doesn't matter. It's a real big challenge.
That's why they don't let me go before Judy.
Translation tables.
Could I comment a little bit though? The manner in which we manage professional vocabularies and terminologies might be quite different than what we need from patients. There's a lot of interest mapping from patient terms to professional terms. I think that may be fine. There's reasons why we may want to use different kinds of visualizations and natural language processing to capture meaning in the moment, not necessarily at the same characteristics of the stable, reproducible criteria we put on professional vocabulary. We have to begin to think about why we want to codify and interpret the data, and then begin to bring the right tools to bear for that.
The only other comment I'll make is I think there's going to continue to be a need in healthcare for both objective and subjective information. And to try to take all the subjective and codify it is going to be a problem. Now, that being said, what do we do with that stuff then? Because it's not really computable, right? I don't know. I mean, I think those are interesting challenges as we think about this patient-generated information. Because as soon as we force patients to use drop-down menus or anything that looks, smells, and feels like choices instead of what they're feeling and thinking, you're already predetermining what they should be thinking, and it defeats the purpose, at least somewhat, of what they're going to be telling you. So that's a challenge.
If I can also point out that sometimes the patient needs to have information processed and fed back to them. It might never need to go to the clinician.
Yeah.
Or we might need to think about various representations over the same data.
Any other questions? Yes, in the back.
Yes, thank you for a very informative panel. My question is to Judy and the rest of the panel. Are there corporations or countries which are using patient-centered care, and what can we learn from them? And is it even possible to apply those learnings to health systems in the U.S.? So can you please comment on that a little bit?
I don't actually know if there's any countries that are sort of doing best practice in this space. Patty, do you?
I think that I've heard of more experiments in Australia and in some of the Western European countries. I'm thinking specifically of Belgium. They tend to be experiments around the specialty care practices, not rehabilitation care, stroke follow-up, etc., not a fully organized system.
What we do know is that the patient-provider relationship is different in different countries. Here in the United States, we've held providers at sort of a different level, and that was never, I shouldn't say never, but it's not often seen as a pairing or a shared relationship. And in countries that have had socialized medicine for a long time, and where physicians in particular, that's quote unquote just a job, if you will. They work in many cases for the hospitals or for the clinics. It is seen as more of a shared space over time. But to say that I've heard specifically what that means or what changed as a result of that, I can't say I've even read much about that. Is anybody in the room familiar?
We probably have time for one more question if somebody has one. Okay, a couple more questions, all right.
I just wanted to comment on a couple of experiences that I had and to respond a little bit to a remark, because there is a certain amount of translatability, I think, between common language that people use and medical terms. I worked in home care for several years, and anywhere you speak at a patient's level, it's there. And I remember once calling a doctor's office and saying to the nurse that the patient developed little red spots around her wound or something. I don't remember exactly, but the nurse answered back to me, "Do you mean petechiae?" So, and of course, with international things, there's a problem. I studied in France for a while, and I had to have a physical, and I had this one really bad episode of vertigo. But I couldn't think of the word in French for it, which is very close to English. It's vertige, but I just couldn't think of it. And I kept saying to the doctor I had this episode of lightheadedness, And in French, to say you have a light head is a very good thing. So we just went back and forth until we got
Language.
trying to understand.
Yeah.
You know?
Right in front of you, Seth. Come forward. There you go. Thank you.
Hi. I work for a behavioral health facility, and we're struggling now. We're implementing an electronic medical record. We found that in our vendor selection that we didn't really fit anywhere. So we do have inpatient beds, but most of our beds are rehab. We found that outpatient programs didn't really work for us because they didn't have the medication management capabilities that we need. But now we're finding that we're really sort of stretching what our vendor can do, because we actually have we're responsible for doing multidisciplinary treatment plans that require input by various disciplines, which sort of send them in a tailspin because they have their nursing care plans and their physician problem list, but they don't have any marriage of those two things, and never mind social work and everyone else that comes into play. And then, by the way, they require a patient signature on them every 2 weeks when they get reevaluated. So do you see any focus coming for these sort of specialty type hospitals or anything like that being done in the government or even just by vendors?
Funny you should ask. Actually, now I'm sitting here being hard-pressed to think about what the acronym SAMHSA stands for. Are you familiar with SAMHSA? Okay, so it's anybody who wants to Google it and remind me what it, but it's behavioral health, an agency at the federal level responsible for behavioral health. They're actually developing an electronic health record for behavioral health, and it's supposed to be out before the end of this year and available as open source, really, for behavioral health organizations, mostly because there has been no proliferation in this space in the free market, if you will, or the public space. So it'll be interesting to see. I was shocked when I heard about it, but then I heard stories like yours, where it's really difficult to find something that has the right kind of functionality, as compared to like long-term care and home care. You know, there's been a proliferation of products that are decent. Even critical access hospitals, the software has to be very different than somewhat traditional acute care hospitals. So it sounds like there's some hope coming on the horizon there. They've actually contracted and they're paying for it, the development of it.
Patty, did you have any comments?
I just want to say I think that we've reached a level of sophistication with HIT that we're going to move away from a monolithic EHR model and start to see more and more examples of distributed tools that are very useful in the local environment and have the capability of being integrated into the back end without having to have the same front end.
We were talking about this at lunch, Patty, Back to the Future. You all met, well, some of you, you're a little younger, but you might remember there was a time when we talked about total distributed systems and they'd all just connect and talk to each other, and we could do best of breed. And of course, that very quickly, because of our lack of standards and everything else, went away and monolithics started to rule. And that's kind of our current reality. But I agree with Patty. I think we're going to see, as interoperability expands, an increase in these sort of best-of-breed niche vendors that can connect the enterprise.
On that note, I'm going to offer that we can stay up front, and Patty can probably stay on the phone a few more minutes if we have any other questions. But I do want to be respectful of the time of the conference, so we have a quick break, and then we'll be starting another session. So thank you very much, and thank you very much to Patty, Brennan on the phone, as well as Judy and Diane at the table. Thank you.